I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island, New York City, and tri-state community. Today's program is about rehabilitative medicine. We're going to talk about new treatments, what's available, both with regard to speech therapy. We have a wonderful speech pathologist here, and rehabilitative medicine as a whole with a physiatrist. Rehabilitation is a concept that really just came to fruition maybe in the last 100 years, where we could take someone who's not doing well and through retraining and different techniques get them better. We see this with neurological conditions, people who have had strokes, multiple sclerosis, Parkinson's disease, orthopedic and rheumatological disorders, speech disorders in adults and children. And people now that we're getting a little bit older, there's been so much going on right now about balance therapy, keeping people stable, because the worst thing that could happen to someone is falling. We're also seeing this also with new cognitive therapies, things to help memory get better, people who've had traumatic brain injury, and we've seen that so much with football players and people who've been in athletics or had repeated head trauma. So my wonderful, marvelous guest tonight. First, I want to introduce Stacy Emmer, who's a licensed speech therapist, pathologist, who deals with both adults and children. She's the director of the TTI speech program and Speech Learn. Welcome.
Thank you.
And Dr. Jack D'Angelo, a close friend, who's a practicing physiatrist, a rehabilitation medicine specialist, and someone who's got tremendous expertise in this field. Both of you, thank you. Thank you both for coming. So now in general, after giving that little introduction, from people who actually do this, what's rehabilitation medicine?
Well, it's an interesting thing. As you pointed out, rehab is about 100 years old as a profession, and really what that means is after World War I, there were actually survivors of a war, and we'd never really had that before, and rehab was really born as a result of military conflicts and worked on getting people back to function. And so in the 21st century, I like to call it it's functional medicine. It's when I see a patient, the patient might come in and say something to me like, I can't walk. Well, they can walk because clearly they got in to see me, right? So that's kind of, it's a term that has varying degrees. So my job is to kind of sort out what does that really mean for that patient and what are the goals we need to accomplish for that patient. So unlike being focused on whether or not the patient can lift his arm up 10 or 15 times, our focus really in the big picture is more like if you need to go up 10 steps, we got to make sure you can get up 10 steps.
And what's so interesting about that, you mentioned walking, we'll probably talk about that a lot, is how many things it takes to walk.
Correct.
You have to have balance, you have to have strength, you have to have sensation, you have to have vision in many ways. Especially if it's lost abruptly, you'll have problems with walking.
Right.
So it's such a complicated task.
And even the act of walking, without all those other variables, we say there are 6 determinants to how you walk, right? And they really start from the moment your foot hits the ground. And all kinds of that physics and algebra and all that stuff we hated when we were in school has a real physiologic purpose when we talk about function.
Let's talk about other fields of rehabilitation. So I have Stacy here, so please tell us a little bit about speech and swallowing therapy. What is it?
Well, first I'll talk a little bit about what a speech-language pathologist is. So a speech-language pathologist, ASHA, which is the American Speech Hearing Association, puts out a scope of practice. So a speech-language pathologist assesses and treats patients who have communication and swallowing disorders. Now, communication is a broad-based term, and communication involves receptive language, which is understanding language, expressing yourself. It also includes cognition. So a speech-language pathologist can work with patients who have traumatic brain injury, and they might have difficulties with attention, they might have difficulties with problem solving, reasoning, memory, and that's an area we treat. They also can work with patients who have fluency problems, voice problems, resonance problems. So it's very broad-based in terms of what a speech-language pathologist can do. They can also work with infants all the way up through geriatrics in a variety of settings. They can work in schools, in nursing homes, in rehabilitation centers, across the lifespan. And we know that communication effectiveness, the ability to communicate effectively, is really the basis for all our relationships. So if there's a breakdown in communication, then what happens is the patient experiences a high degree of frustration. So if you're a child or if you're an adult and you can't communicate effectively, you're going to be very frustrated. So that's where a speech language pathologist comes in. And when they come in, we do a thorough assessment, and we want to see where the area of breakdown is. We want to talk to the patient to see what their goals are, because like we were saying, what happens is the goal of what the patient's goal is the most important. And then we want to work on it. So we can work on it in two ways. One way is you can compensate. So for instance, if somebody has a memory disorder, so a compensation would be that you have a memory book or an alarm. And you can work on a restorative level. So on a restorative level, you're actually trying to work to restore the function that was lost. So you're using restorative therapy and you're using compensation in order to make the patient communicate most effectively. So that would be the communication piece. And on the swallowing aspect, eating is something we all take for granted. But what happens is sometimes when you have a stroke or if you have a degenerative disease, you can't swallow well anymore. So a speech language pathologist is going to come in and they're going to do an assessment. So first they're going to do a bedside assessment, and they're going to give you a variety of different consistencies: applesauce, a banana, a cookie. We see how you swallow. We see where the breakdown is. Is it at the oral level? Is it at the pharyngeal level? Are you coughing? And basically then we try and give you the least restrictive diet so that you can be safe and not aspirate.
So in a sense, both with walking and speech, they're very complicated things.
Right.
But what you see is, long before working on teams became cool in medicine, rehab was always a team discipline.
Right.
We always worked as a team. There was always a physiatrist, a speech therapist, an occupational therapist, a physical therapist.
So give me some definitions. We're still in the very beginning. What's an occupational therapist, a physical therapist?
Okay, so in brief, we'll make it as simple as we can, right? The physical therapist really focuses many times on gross motor function. So the ability for a person to get up and off a seat, off of a chair, the ability to go up and down steps. The occupational therapist very often will focus on what we call those activities of daily living. So that's the person helping the person be able to dress themselves, helping the person to bathe themselves, helping the person to move around their home and cook and do that kind of stuff. And whatever adaptations that we bring into that to make them able to do that. And really, it's a total team approach, up until even including someone like an orthotist or a prosthetist who may make braces. We might have an amputee that we need to get a prosthesis for. Everyone is really working as a team, looking at, because so much of this crosses over.
Right.
She can be working with someone who has cognitive deficits, and so is the occupational therapist. And only working as a team can we get that patient to the next level, because so much of what we do is crossing.
So let me ask about training. What kind of training, as a physician, as a speech pathologist, what kind of training, how many years? I think everyone out there is interested that not anyone could be doing this without a lot of expertise. So just within really very short term, about what kind of
So
training
briefly,
specifically?
in physiatry, and I often say physical medicine and rehabilitation, because when I say physiatry, people think I'm a psychiatrist or a psychologist or a podiatrist. But basically, as I stated earlier, I started out in pediatrics, so I was a pediatrician first, and many of my kids were getting PT and OT. And I had no idea what PT and OT really did with infants. I had never been exposed to that as a student or as a resident. And as I got more curious about it, I thought, well, maybe this is something I should be doing. This is something I should be involved in. You go back, you have to do a completely second training program. In medicine, there's no such thing as an apprenticeship where I could follow a specialist around and learn the skills of that trade and then adapt them to the profession. You really have to go back and do a whole nother residency program, which is basically another 3 years after a first general year. And that's really what qualifies you as a physical medicine or as a
So let me ask
physiatrist.
Stacey about being a speech pathologist.
So a speech language pathologist holds a clinical certificate of competence. The minimum you have to have is a master's degree, and the education is both the academic coursework, and then you do a number of clinical placements where you train underneath a licensed speech language pathologist. So you can work in a rehab hospital or a school or a private practice, but you're training with another speech language pathologist who then deems that you're competent. So it's a combination of the coursework and then the clinical training. Once you have your clinical certificate of competence, you continue your training. You have to do a number of professional development courses, and usually people tend to specialize after they graduate. So the way it works with speech is you have to take a broad base of a number of different classes, and then when you graduate, you then will specialize in a specific area. So if you're going to specialize in adult neurogenics, then you're going to specialize your professional development in that area, and you could become an expert in that area.
So it's interesting, as a neurologist, I see a lot of people with speech problems.
Right.
And we have patients who've had strokes, people who have problems with MS and Parkinson's disease. A lot of these things come into my practice on a daily basis. And we assess speech. And neurologically, you assess speech by seeing if someone's fluent and naming and comprehending and reading and writing.
Right.
Tell me, what do you do? Because your speech assessment is clearly different than mine.
Right.
Mine is to localize where the problem is, to find out what I could do medically for this patient.
Right.
When you have somebody who comes in who's got a speech problem, first of all, how should I or Dr. D'Angelo or any of the internists, primary care physicians out here, know when to send someone to a speech pathologist?
Right. Well, I think the way I assess basically is when somebody comes in initially, and then we'll talk about when to refer. The first thing you have to do is a thorough case history, and you really want to see what the underlying issue is. Usually we'll have a CT scan or MRI or information from the physiatrist or from the neurologist. And then you have to have a scaffold for assessment. So there's a number of standardized tests, and then there's informal assessment. But the way you look at it first is with language. So first you're going to look at receptive language, which is how much the patient is understanding. So we might do a number of things like following commands, pointing to objects, understanding conversation, understanding paragraphs, and you want to see where the breakdown occurs. Is it at a very simple level, or is it at a more complex level? Then you want to assess expressive language. You want to see if the person has a word-finding difficulty, if the person has verbal apraxia. You want to see how the person verbally sequences. So we want to get a picture of the person's language and see where the breakdown is. You want to know their strengths and their areas of weakness, because you want to use their areas of strength to help them basically compensate. We also assess cognition. So in terms of cognition, there's a number of tests that you could do for attention, for memory, for problem solving, for executive functioning. So you can have, again, a standardized test or more an informal test. So for instance, even for executive functioning, you want to see if the patient could plan. So executive function is involving initiation, planning, problem solving. So I might give them a list of errands to do. And then I would say, let me see how you plan your day. But there'll be some areas that are a little more difficult. You have to make an appointment, you have to pick up a cake, you have to order the cake and pick up the cake, just to see how they can problem solve. So again, you're looking for a broad base of how the person is functioning in terms of their receptive and expressive language, in terms of their cognition, in terms of their reading and writing, through a standardized assessment, through informal assessment, through interview with the patient, interview with the family, and most important, I feel, is the patient's goals. And that is important because whatever the patient wants to work on, that's where their motivation is going to be. Okay, so what I find also, the research has shown, especially say in the area of aphasia. So if you're working
aphasia
on...
is a language problem.
Correct, so it's a language problem. You have a stroke and you have difficulty communicating. So the research has shown that if you have word-finding difficulties and you want to communicate with your grandchildren in a dialogue, if the speech therapist focuses on those words in the dialogue or specific words, those are the words that the person can then learn again. The generalization is a little weaker. So you want to know what the person's goals are, because if they want to be able to go order a pizza at the pizza store, then those are the words that you're going to work on through different techniques. So in any therapy, the goals of the patient are the most important. And I find sometimes, I'm sure you find this too, that what happens is the therapist comes in, they do the assessment, and then they say, okay, we're going to work on X, Y, and Z. And the patient's sitting there like, well, what about what I think?
Right.
And when the person is motivated and the person basically feels that they're in it together with you. And I just have a little story to share, if I can, about
Sure.
this. I have a friend, she's a fluency specialist, and there was a man, and he was a stutterer from when he was little. And he started dating, and he found that people would only set him up with other people who had disabilities. And he came to the speech therapist, and he said, I may stutter, but cognitively, I don't have an issue. I'm just as smart as the next person, and I'm motivated to get better. She worked with him on a number of techniques, and with fluency training, it's really compensation. You're given a number of techniques, and he practiced, and he practiced, and he practiced until he became more fluent again. And he started dating, and he came to her, and he said, the difference between man and an animal is speech. And I always felt more like an animal because I couldn't speak.
Wow.
And now that you've basically taught me these techniques, I feel more like a human again.
What a
So
beautiful
I
story.
just
What
think
a
that,
beautiful
like, when
story.
you know the client's goals, then
Right.
you really can focus your therapy.
And,
So I think
and I'll actually
that-
mention something that I mention to my residents every day. When someone is aphasic, it's a problem with language. It's not just talking.
Right.
So if you are deaf and you sign, you can't sign if you're aphasic.
Right.
You can't write if you're aphasic. There's a problem with all language skills. So
Right.
very, very interesting. So let's move on a little bit
And yet
to
they're
some-
still there, right?
They're still
Right.
So
there.
very often we start to talk to them differently, or as if they're cognitively not there,
Right.
because we can't communicate with them.
Right.
It's our, we bring to it our own personal failings sometimes in that.
Right.
In that
One thing they
approach.
should teach people in medical school is if someone comes in and speaks a different language than you do, speaking to them in English as loud as you can and as slowly as you can won't help.
That's
Right.
correct.
And we've learned this over the years, doing it very slowly, very loud. People just think you're yelling.
Right.
But we just feel that if you do it slow enough, that everybody should understand our
That's
native
right.
language.
But I think it also speaks to the need to do education and training. One of the aspects of all the therapy, physical therapy, occupation, and speech therapy, is to really train the partner, the communication partner, family, caregiver, how to communicate with the patient. And that's so important. And we found that when a person is trained, research has shown that if a person is trained how to work with a person with aphasia, you'd be amazed if you're working with multimodality, if you have them write, if you have them gesture, if you have them do a variety of things, they can get their message across.
But that's really what I want to bring us out into, because again, what you've said and said so eloquently is really a lot of this has to do with the person, what motivates them, what motivates the family. What I'd like to try to bring the community, our audience, is the idea about new things in rehab. I mean, we could have talked about rehab with speech therapy, and again,
Sure.
techniques are similar, whether it's exercise type things that we do with physical therapy or repetitive type things to get processes better or help break down walking and get better. I'm actually looking, in a sense, to give an idea, and we'll talk about it with speech in a moment, but with regard to physical therapy, rehabilitative therapy, bracing, electrical stimulators, give us a little idea what's new compared to when you came out in practice. And I won't say how many years we've been in practice, 'cause
Right.
we've been both out a while. An idea, what kind of things are out there in 2017 that might not have been there
Well,
before?
I would say probably the greatest benefits have been in prosthetic devices. Some of that has to do with the fact that technology in different areas caught up at the same time. So medicine was able to make use of computer technology, the miniaturization of computer technology, and those feedback loops to create prosthetics that more seamlessly work with one's brain and pre-existing nerve function. So I think that's been a very dramatic improvement. Certainly, we also talk about equipment in general. It comes part of what we do as rehab docs. So, for instance, things like wheelchairs. Wheelchairs have made dramatic changes in my career in terms of positioning of patients, giving patients greater independence in a chair than they would have had. Simple things. You live your life in a chair, you realize you never reach the top shelf in a supermarket.
Absolutely.
Right? To have a chair that kind of lifts up so that you can reach the top shelf, that's something. That's really a dramatic thing for someone. So it's things like in that area that I think you see the greatest differences. In terms of treatment interventions, we are all familiar with things like ultrasound and infrared therapy, heat therapies, light therapies, cold therapies. What's changed in that is not so much that we're using something we haven't used before, but that technology is allowing us to use it in a different way. So we are more computerized. We can keep more data in terms of how a patient is progressing in comparison. I think you see that a lot when we talk about falls, right? With falls, basically much of our falls treatment is based on the use of computers and creating ways for patients to kind of integrate their body function and their visual function skills and giving them feedback to do that more progressively with uses of television screens and things like that.
So you mean it's not just for your golf swing?
Exactly.
So we're actually able to see how someone walks and break down, like a baseball player, how they swing to see what we're doing.
That's exactly right.
And I think you made a wonderful point earlier when we talked about the military. The Civil War actually caused the medical community to know how to do surgery.
Right.
World War I was where rehabilitation came out.
Right.
Now with our wounded warriors, people who are coming back from various conflicts, coming back, the idea that we watch on television and different things, that we're getting different devices.
And that's where it's all growing from, right? So all our prosthetics really first emerged from the military. They really do, because that's where the need is the greatest. That's where there's unlimited funding. They're not dealing with having to get authorization from an insurance company for a special prostheses. So that's really where it comes from. And we learn from that, right? And from that, we translate it outwards. Our biggest challenge really moving ahead in the military is the fact that we have so many head injuries.
Yes.
Now, and that's really our biggest challenge as a community, because these are people that are plagued by not just physical deficits, but control of emotional ability, and it limits their ability to function in a workplace, in their homes, with their spouses, with
I'm
their
seeing
children.
so much of that. I actually have professional football players who come to our practice, to my medical practice, who have chronic traumatic encephalopathy, which means injuries from professional players who are in their 30s and 40s who are cognitively very impaired. And this process has become progressive, sad to say.
Right.
And that's where we see so much of it. I mean, and the irony is I see so many high school kids who play football or hockey or soccer have head trauma, and then after one event, most of them are fine. But then you talk to mom and dad and say, well, if this happens again and again and again, we have a lot of problems.
And it does raise issues, right? It raises issues on things we've managed for years, never really looking at them through that lens. So when someone starts to have behavioral changes or cognitive changes, and their ability to function is not the same as it was before, maybe it is because of the things they're doing and the trauma that they're getting. And we've never really looked at it that way necessarily. I'd like to ask you a question that I think people would be interested in. So much of my career has been dealing with patients who have cerebral palsy. And as most of us know, cerebral palsy is not necessarily a cognitive
Let's just say it's cerebral palsy. That's a birth-related brain injury.
Correct. So for a period of time, right, the brain was denied oxygen for one reason or another. And we have these motoric deficits more than anything else. But many of these people are cognitively intact, but just have bad communication skills because of their motor issues. So augmentative technologies have really been helpful. So I'd love for you to kind of share some of that.
And I was going to say, in the area where the development is, I think, like you said, for technology, for a lot of the prosthetics and the wheelchairs, for speech, we've seen that as well.
Right.
And I think the area of augmentative communication, due to the access to technology, has helped so many people. I remember when I first graduated, if you wanted to get an AAC evaluation, I remember having to send them to a special clinic, which was very far away, and then it was difficult for the patients to go to. So now with patients, for instance, if you have ALS or you have any other degenerative disease, or if you have CP, your access to AAC is that much easier. So we have the training now even in school. There are special courses that they take where the students are actually taught how to use the technology, how to use the eye gaze technique.
Right.
I help run a graduate program right now, and I was in over the summer, And the vendor brought the eye gaze techniques, the eye gaze machine, and was teaching the speech language pathologists how to train to use them.
Right.
And what happens is then these clients are able to get the machines earlier, they're able to be trained on them, and they're able to utilize them and able to communicate.
And
So
these are things people use.
They really
you know?
use.
So much of what we sometimes prescribe ends up in the back of a closet somewhere.
Right.
This is not one of those things. The expense spent here, it comes back
Correct.
100-fold.
And also, it used to be that the machines were very big. So say the Dynavox, it was
Right.
a big machine, even for patients who have, aphasia or apraxia, and also for children. So the kids didn't want to travel, carry them around.
Right.
So they would pay for them, and then they wind up not being used. But now everything is portable, everything is much smaller, and it's easy to use.
Right.
So the children with autism are using it, with cerebral palsy are using it, as well as adults who have any kind of degenerative disease, and they're finding that their communication skills are much more effective.
Oh,
And
yeah,
much
it
of this
just
is provided
opens
by
up.
the school system, by the,
Yeah,
by the
and
city. the
insurance is
state.
also starting to really pay for these things because they see the effectiveness in it.
We're going to finish up on pain a little bit.
Okay.
And so many people have chronic pain. I mean, we've talked in the past about opioids and different things that people are using in excess, and very tragically what's happening on Staten Island and New York City. As someone in the physiatry field, physical medicine, rehabilitative medicine field, what things could we offer people who are having terrible pain?
So, we all use the buzzwords pain management, but really very often we're just managing a sector of the pain, like what I do is what I'm managing. It's not really a global team approach to managing pain, which is really the key. There are, whether or not someone complains of cognitive issues when they're having chronic pain, there are cognitive issues. There are social issues, huge social issues. There are behavioral issues. There's lots of things, right, to manage pain. Not all of it comes in a bottle. And I think that's an important take-home message, and where we have not been as aggressive as we should be. We went from not having lots of things to having lots of injections, medicines, tricks to do to somebody.
Injections like pain shots,
Right.
like
So whether
steroid
they're
shots and
nerve
things
blocks, whether they're steroid injections, but we still don't manage the whole patient, because our behavioral intervention or our healthcare behavioral services are the weakest part of our healthcare system.
Absolutely.
So we don't really manage that as completely as we should. Everyone knows there was a guy several years ago by the name of Dr. Sarno, and Dr. Sarno's approach to back pain was really all cognitive. It was all cognitive. It had to do with nothing else.
And that's why things like hypnosis, acupuncture, there's so
Correct.
many different parts. I want to thank you guys for
Thank you.
being here. I mean, this was a marvelous introduction. I mean, we could do this for hours and hours. And just the idea of how many things are available to our patients, our clientele, our community as a whole, both with regard to rehabilitation, getting people to be less in pain, to help people with speech, whether it's pediatrics or adult. I just want our patients to know, and as a neurologist, I see this so often, that people come in feeling almost hopeless, helpless,
Definitely.
and helpless. And at this point, we are able to provide so much more than we ever were before because of specialists such as yourself.
For years, I said we've had the best job because we come in after all the problems. So we are the beacon of hope.
Thank you all, and good night.